Diabetes foot care pathology. The key objectives are to understand the pathology and clinical presentation of diabetic foot, to understand when and how to intervene, and to understand basic wound care. There are three main pathologies, namely neuropathy, deformity, and vasculopathy. Based on these, diabetic foot can be divided into various stages such as low-risk foot, high-risk foot, and active foot problems. This classification will be discussed in detail later in this training module. There are various clinical syndromes that can be identified as mentioned in this slide. Neuropathic foot is the commonest presentation. Other entities are neuroischemic foot, critically ischemic foot, septic foot, and Charcot foot. Diabetic neuropathy. 70% of people with diabetes have peripheral sensory, motor, and autonomic nerve damage. Sensory neuropathy, LOPS, loss of protective sensation, leads to injuries of the foot. Motor neuropathy causes small muscle wasting of the foot, which in turn contributes to the development of deformity. This can change the biomechanics of the foot and produce calluses and ulcers over bony prominences. Autonomic neuropathy reduces moisture of the skin due to denervation of sweat and sebaceous glands. This leads to fissuring of the foot. Impact of neuropathy can be summarized as shown in this slide. Neuropathy will lead to loss of protective sensation and undetected trauma causing wounds. Commonly seen deformities of the diabetic foot disorder are claw-toe deformity, which is the hyperextension of the metatarsophalangeal joint and flexion of the interphalangeal joint, calluses and ulcer formation over the bony prominences, thinning of the fat pad over MTPJ, loss of plantar arches, hammer-toe deformity, which is hyperextension of the MTPJ and extension of the IPJ, and overlapping toes. This slide explains how a neuropathic foot with prominent metatarsal heads can lead to callus formation and pressure ulceration over the plantar forefoot. Neuropathic foot with plantar ulcers surrounded by callus. Treatment needs careful attention to foot care, callus shaving, and offloading of plantar pressure points using footwear. When an ulcer is developed, appropriate wound care and referral to tertiary unit for surgical care is recommended. Foot tissues can become ischemic because of macrovascular disease or atherosclerosis, but can also be complicated by associated microvascular disease. Microvascular disease is a non-occlusive disease, and presence of it does not exclude a patient from revascularization if required. Ulcer healing is impaired due to poor foot perfusion. Tissue necrosis and gangrene can be seen in advanced PAD, critical limb ischemia. PAD is an independent risk factor for death and limb loss. Clinical assessment of an ischemic limb involves proper history taking and observations for peripheral stigmata of vasculopathy, namely skin atrophy, hair loss, atrophy of toes and toenails, and absent peripheral pulses. Measurement of ankle brachial pressure index is an objective bedside clinical test that can be used to assess and grade the status of PAD. If PAD is present, it is recommended to refer the patient for vascular opinion. This slide demonstrates some of the clinical presentations of severely ischemic foot. Treatment for PAD includes peripheral arterial bypass or angioplasty, which can be performed successfully. Charcot foot is a rare progressive condition that involves the gradual weakening of bones, joints, and soft tissues of the foot or ankle. seen in patients with severe peripheral neuropathy. 25% of diabetics with this pathology had wrong initial diagnosis. Infection, gout, arthritis, fracture, venous insufficiency, and tumors. Charcot arthropathy can be diagnosed using foot x-rays. MRI scan can show changes at an early stage, even before the development of X-ray changes, in stage 0, thus enabling treatment to be started sooner. MRI taken during first 4 to 6 weeks of the disease will demonstrate significant bone marrow edema of the navicular, medial, middle, and lateral cuneiform bones, and at the bases of several metatarsal bones. MRI offers the highest diagnostic accuracy, ligamentous disruption, concomitant joint deformity, and the center of signal enhancement within joints and subchondral bone. In complex regional pain syndrome, no changes occur. Immobilization from the beginning is the key to prevent development of chronic disabling Charcot deformities. Diabetic foot infection is an important condition that needs early diagnosis and prompt treatment. Because of neuropathy, diabetic foot infection do not always present with the classical signs of inflammation, that is swelling, redness, warmth, and pain. They are often subtle at the beginning, need vigilant examination to be detected at an early stage. Perform probe-to-bone test to exclude. If bones can be touched through the wound using a probe, the probed bone will be considered as having osteomyelitis unless proven otherwise. Superficial mild infections are usually due to Staphylococcus and can be treated with oral flucloxacillin. If there are evidence of deep infection or infections not responding to initial antimicrobial therapy, this would require hospitalization. Presence of ischemia and infection in combinations can be a rapidly progressing condition which could result in rapid loss of tissue. This is also called foot attack because if not treated promptly, a major amputation could be inevitable. Therefore, refer these types of patients immediately to a vascular unit directly without delay. Basic diabetic foot ulcer care includes identify the cause of the wound and remove it, or consider how to prevent recurrence. All superficial wounds should show signs of healing within 3 to 5 days. If no evidence of healing, refer immediately. There are 3 main reasons for a wound not healing or deteriorating: poor arterial supply, recurrent trauma or high plantar pressure, and deep infection. When applying a wound dressing to a foot ulcer, follow following principles. Apply simple dressing and change regularly as required. Clean the wounds whenever it is required only. Arrange regular review appointments. Give clear and simple patient advice or information on wound care. In summary, there are 3 main pathologies: neuropathy, deformity, and ischemia. Prevention of development of foot compilation is the key. Early diagnosis is important. Natural history can be rapidly progressive, leading to necrosis and amputation. Therefore, refer patients with acute foot problems to a tertiary care center without a delay. Thank you.